Is sponsored by Intas. It gives me great pleasure to invite our speaker, Dr. Ashish Singh, medical oncologist from Vellore, and he'll be talking on the topic recent advances in the formulation in novel formulations of taxanes.
Good afternoon. Thank you. So we are going to talk about in this Intas-sponsored symposium advances. I would not say recent advances because this drug has been around for some time. But I would say this is an important advance because we all know taxanes are important for our patients, and only after platinum, if you look at any other class of drugs which we use often, so that remains taxanes. Now both paclitaxel as well as docetaxel. For all of us who have seen these two drugs evolve, we know why was there a need for newer taxanes or better drugs, because initially when we had paclitaxel alone, that chromophore based paclitaxel alone, there used to be, it was very common, even during our training we would get one call every week that this patient is having an anaphylaxis or this patient is having an allergic reaction, and we sometimes even had to like resuscitate them, take them to ICU. So it has always been a challenge, especially with chromophore based paclitaxel. Also, then came docetaxel. Like in between, there was another one called, I think BMS had another taxane, and then we had cabazitaxel and other things. So generally, there's no doubt that these agents are very useful, and we would want to use them. But the challenge has been how to manage their toxicity, right? Be it neuropathy, allergic reactions. And the good thing about these taxanes are they're not that myelotoxic, at least paclitaxel. So we are able to use them in combination with platinum and other agents. So now so today I'm going to talk briefly on both a newer preparation of docetaxel as well as paclitaxel. But before we get into these individual drugs, let's look at what is it that we have changed. So what they have changed is they've used this thing called nano-aqualip technology, and what it does is it basically takes away the carrying molecules, whether it's polysorbate 80, which is predominantly responsible for your allergic reactions, and we all know docetaxel allergic reaction would require a lot of pre-medication starting the day before chemotherapy, and that has its own set of problems. Right, and the incidence is pretty steep, especially with Taxotere. We all have seen that even in our practice. So much so that even when this regimen dosi-cyclo became popular everywhere else, in India we were almost worried, and we would not be using these because febrile neutropenias, diarrhea, and mucositis used to be a huge challenge. Now, so that's the problem now. So if you have a problem, you need to find out what the solution is. Now the solution is to deliver the same drug in the same concentration, in the same pharmacokinetics, have the same clinical outcomes, but do it safely. So in this technology, so it's basically this NDLS technology is lipid based. So you know you have these hydrophilic and hydrophobic entities, and your drug is kind of embedded in between, and so that the delivery can happen without, so that the molecule is stable and it reaches where it is intended to reach, right? And so how is it advantageous? Now, number one is if you say it is a completely aqueous based system. Also things like leaching of the plasticizers from PVC bags, IV set is not a concern. On the other hand, because of this, your hypersensitivity reaction is reduced, and also it's less safety concerns with that. So you may ask that if it is such well guarded the molecule, how does it reach the tumor? So the way it works is the tumor tissues, they have leaky vasculatures, so therefore this one would leak through them, and being aqueous soluble would also help. Now we need to have comparison to see whether pharmacokinetically they achieve the same what is achieved with the standard, which is Taxotere here. Now this is data on file, slides provided by the sponsor, but what we see here is the Tmax, the Cmax, and also the AUC seems to be similar with a half-life of about 21 hours. and the same figures now plotted on a curve tells you that these two are overlapping in terms of the pharmacokinetics. Now, do we have studies in the patients? So this is one publication in 2014, which is again, these are smaller studies, but they have done it in a randomized way so that we take out any biases. And most of these studies, because they're small, they're looking at response rate as their endpoint. So this was a study in breast cancer patients who had prior chemotherapy, and when you look at the response, you have most of the responses are partial responses, and they're comparable, right? And this is what we expect, 35% response rate with docetaxel in patients with advanced breast cancer. Now, comparing the side effects profile, if you look at what we usually concerned about, the allergic and anaphylaxis, which they have not given you in this slide, but in terms of other things like myelotoxicity, diarrhea, febrile neutropenia, that is comparable. So this was one of the first actually published reports of the efficacy of this drug, and based on this, I think the drug has been available now for a couple of years, and we all have good experience using it. Now, moving on to another study which I think the company used to get approval for foreign markets, and here they studied this drug in 3 doses, 60, 75 and 100, and then they could show that the response rates were actually did increase with increasing dose, right? But most of us would probably not use the 100 milligram per meter square dose, and based on this, they have also they've planned another large study, almost 657 patients in triple negative breast cancers. Okay, so now this is again will be they're looking at doing it in a randomized way, right? And then objective here again the endpoint is going to be response rates again. Now, there are other studies have been planned. I personally have not seen this data, but at least the company is trying to develop it in head and neck cancer, lung cancer, prostate cancer, and also in gastric cancer. So these are the areas where we need to individually study. Now, that's another thing, that do we need to look at these sites separately, or we can put them all together? But I think for regulatory purposes, they will have their approvals is based on a disease diagnosis. So that's how they're doing. Now we have some more data in lung cancer. This is again 40 odd patients, two different doses, and this was presented by Dr. Chetan Deshmukh. I think is just recently concluded ESMO. Again, we are looking at response rates, and if you see the response rates here is, this is lung cancer, so don't expect great responses. But if you look at stable disease or disease control, seems to be in line with what you expect with a drug like docetaxel. So again, what I'm trying to show you is multiple experiences across different investigators and institutions. They're all replicating the safety and efficacy of this formulation of docetaxel, right? Also, there is about 50 patient study where the DCF regimen, which is a toxic regimen, and there again this was tried, and again you have a response rates which is about 64%. Now this is a little higher, but again these are all unpublished data, so we really not peer reviewed, so we do not verify how the response was assessed. Now breast cancer is another I would say common indication where docetaxel is used. This is again a very small study, I think comes from Omega Hospital, which is in Hyderabad, which they have looked at this formulation in about 60 patients with neoadjuvant breast, and they also have noticed very good regression of this tumor, right? So moving forward into the paclitaxel drug being formulated in this combination, again whatever results we have, they have conducted in a small studies, but at least they have randomized them, and what we see is the response rates are quite they're as what you would expect with a drug like paclitaxel, right? So we also this is again 174 odd patients. Again, this is presented as an abstract, but here the numbers are 85, 45, 44. These are multi-center studies, right? And again, looking at response rates. So when it comes to side effects, what you're trying to prevent is allergy and anaphylaxis, but other side effects would be as expected. Neuropathy, myelotoxicity would be very common. So in conclusion, this is a technology which enables us to deliver this drug in a more tolerable way, and therefore does allow us to kind of safely do it as an outpatient daycare procedure. And this is not only that this technology can only be used for intravenously, they're even trying to develop in an oral form of cabazitaxel, and this is something which I think we are all very happy to have it developed within our own country, and with all these benefits of reduced hypersensitivity reaction, steroid sparing action, using an aqueous formulation, and also maybe in future an oral product. These are something which we are all happy about. Thank you for your attention, and we have a panel discussion now.
We have a question. So I just wanted to ask, the approved dose for Abraxane, which is another paclitaxel formulation, is in breast cancer is 260 mg per meter square every 3 weekly. So, but most of us, what we see in our practice, that whatever paclitaxel newer formulations come, we generally give the same dose as conventional paclitaxel. So what is your opinion about that? Should we give more dose of these newer formulations, or it is dose by dose? That means if Pacli is given 175 mg meter square 3 weekly, or 80 mg or whatever, 80 mg meter square weekly, then same should be used, because if you whatever trials that you have shown, they have used the same dose as the conventional docetaxel or conventional paclitaxel, when the approval for Abraxane is for a higher dose. So what is
exactly. So paclitaxel, again, Abraxane is a slightly different formulation. That's an albumin bound one. And we also have other formulations like nanoparticles. That's a different formulation. And then we have conventional, and then we have Pacli Aqualip. So we've got actually 4 different formulations. Now, and why is it that we are not able to give 200 or 225 milligram per meter square? It's because of toxicity. So Abraxane, being albumin bound, allows us to give that dose. Now can we give Pacli Aqualip at Abraxane dose? I suppose we can, but again, just because you hit that dose doesn't mean it's not albumin bound.
So that should these newer formulations given at the same dose as conventional Pacli, or
as of now they are not claiming to be albumin bound, and they're not claiming to be a generic of or a biosimilar of Abraxane. So they are more like Taxol and not like Abraxane. So but then having said that, like if I'm using it weekly, and the dose is, can I hit 125 per meter square, especially if I'm using an adjuvant triple negative, then I know those Abraxane trials are slightly better. I suppose you can, because anaphylaxis is not going to be a problem.
Yes.
But whether neuropathy even with Abraxane we get more neuropathy. Higher the dose, the more the toxicity, but in terms of safety, I think we can. But we should not claim that this is Abraxane. That is what I'm trying to say.
Thank you. Thanks.
Thank you so much, sir. We'll move on to our panel discussion. Our moderator is Dr. MV Chandrakanth, medical oncologist from Kolkata, and the panelists are Dr. Chirag Desai, medical oncologist from Ahmedabad, Dr. Kripa Bajaj, medical oncologist from Hyderabad, Dr. Vijay Patil, medical oncologist from Mumbai, and Dr. Hollis D'Souza, medical oncologist from Mumbai.
So in the coming 15 minutes we will discuss on docetaxel. But before we go to the docetaxel, Dr. Ashish already discussed on docetaxel data. I will go through the docetaxel, how to handle docetaxel, and then we will go to the docetaxel part. Okay, so this is how the conventional docetaxel is. acts on the microtubule. Yeah. So these are the docetaxel dosing, as Dr. Amol was just asking, what dose, whether weekly, 3 weekly. So, so these are the doses of docetaxel, 75 milligram per meter square 3 weekly. Then we can use 60 to 100 milligram per meter square 3 weekly, 25 to 35 weekly. So these are the different dosing patterns which we can use. And weekly doses preferred in palliative or even in CTRT setting we are using right now. And coming on to the dosing, so experience with common dosing schedule, which dose when to use, so what is the difference in efficacy, safety, so how is weekly and 3 weekly different. So Holis, you can start. So when do you use weekly docetaxel? You can mention 3 weekly, weekly, 2 weekly, what doses do you use?
Either 2 weekly or 3 weekly. If it is to be used weekly, I prefer pacli, and docetaxel as a medicine I will not use in a palliative setting. I'll always use an alternative.
So, Vijay sir, coming to you. So, in prostate CRPC, we have 3 weekly docetaxel, we have 2 weekly docetaxel, and weekly docetaxel. So, when do you use weekly, 3 weekly, and 2 weekly? In what situations?
Chandrakanth, we have a unit policy, and our unit policy in prostate made by Dr. Joshi is to use 2 weekly docetaxel. So we stick to that in prostate cancer. If it is lung cancer, second line, I tend to use docetaxel 3 weekly, but this is in a fit patient. In head and neck cancers, I have used 3 weekly docetaxel with 75 milligram per meter square. And in along with as a chemoradiation in cisplatin unfit patient, I have used docetaxel 15 milligram per meters weekly. So this is my experience with docetaxel.
Correct. So perfect. So that is how the data looks like. If you use a weekly docetaxel, probably it has less neutropenia, there are lesser response rates, but there is a higher skin toxicity and fatigue. So this is in palliative setting and is not in the CTRT setting. So the neutropenia component is low, but the skin toxicity is little higher with weekly. That is what we have. So this is how a docetaxel vial looks like. It has more of alcohol in it. You can see the polysorbate, and then we have alcohol, and then there is a non-aqueous solution. So these are some black boxed warnings. What is important is you can look into the LFT. LFT is most important when you come to docetaxel. So you should avoid using docetaxel if bilirubin is above upper limit of normal range, or if the enzymes are 1.5 times upper limit of normal range, or if the alkaline phosphatase is above this. So LFTs are a big problem with docetaxel. So these are the adverse events. Neutropenia is a class adverse event, anaphylaxis is a class adverse event, and then you have fluid retention, which is important despite dexamethasone pre-medication. And these are other adverse events like enterocolitis, neutropenic colitis, second malignancies, cutaneous reactions, neurologic reactions, eye disorders, asthenia, alcohol content, these are some. So if you look into the LFTs, so you look into neutropenia, thrombocytopenia, anemia, or even sepsis, infection, all these are higher when there is deranged LFT, in contrast to those who have normal LFT. So Chirag sir, so how do you look at these LFTs, and how do you dose modify docetaxel when there is an LFT issue?
So if there is a gross derangement of LFT, I will avoid using a docetaxel rather than modifying the dose. But if metastatic, let us say metastatic breast cancer, I will prefer weekly paclitaxel. If it is metastatic prostate cancer, with grossly deranged LFT and liver metastasis, I will do the biopsy to find out if it is a small cell or neuroendocrine tumor. So I will avoid using docetaxel in short.
Fair enough. So docetaxel and liver is what we need to remember. And then this is how we administer docetaxel. You can look into the PVC and then the DHEP, the classical way we administer conventional pacli, the same way we do for docetaxel also. And then so docetaxel hypersensitivity, it can happen within minutes or hours, and re-challenge will have much severe adverse events, and even with pre-medication 2% of patients experience life-threatening side effects. And this is the tween 80, is the one surfactant that is there along with docetaxel, cabazitaxel, that makes it hydrophilic. And this is the range of hypersensitivity, even with pre-medications, you can have hypersensitivity of 8 to 13%. And this is how the antibodies generate against not the taxane in itself, but for cremorphor or the polysorbitrate, that is where you develop antibodies. So the problem is steroids as pre-medication. So, Dr. Kripa, so how do you give, ideally this is how the guideline is, 8 milligram of dexamethasone orally every 12 hours, 1 day prior to chemotherapy, and 10 milligram dexa IV 15 minutes before docetaxel, and 8 milligram dexa every 12 hours for 4 days. This is the recommendation for docetaxel. So do you follow this?
No, sir. Currently we are not, I am not following at least this. Day one I do give 16 mg stat like a pre-medication. Otherwise I will not give this pre-post like itna intense steroids. But I do give prednisolone maintenance for 5 days post that, but not dexamethasone with this high dose.
Okay, so Hollis, what is your practice of dexa along with docetaxel?
The night before I give the dexa dose and continue it 4 days post docetaxel.
Okay. So Vijay sir, so you feel giving dexa along with docetaxel is a challenge? It may cause, so it is a lot of dexa, prolonged dexa can cause immunosuppression, diabetes, osteoporosis, all these are there in those patients who can live long. So do you think this is a challenge for you to give so much of steroids?
It's a challenge, but we also give dexa as a pre-medication, and we also give dexa for the next 3 days. So I think that is necessary. It decreases the side effects of dexa. So we administer it. It's a challenge, but it needs to be given.
So if you can eliminate some part of steroids, so do you think is there an advantage with this novel formulation over the conventional docetaxel?
See, for me, if you want to say that the newer formulation has a better outcomes with the traditional docetaxel, then the answer needs to come in a randomized study. You need to do a randomized study. You need to show that the requirement for dexa goes down, and that requirement of lower dexa actually leads to lesser hyperglycemia, lesser side effects, lesser dexa related issues. If they are not been shown, then I am a bit critical of without having a data saying that.
So this is the data we have right now, sir.
So I would go with this randomized evidence. Then I am more in favor of saying that lesser amount of dexa helps.
Okay. So this is the awareness of adverse events associated with prophylactic corticosteroid use. In conclusion, this study suggests that adverse events associated with prophylactic steroid use should be better recognized. Optimal management of steroid-induced hyperglycemia is recommended to reduce infection risk during docetaxel therapy. Further studies are required to. So as Dr. Vijay said, so we want more data, but there is some report of infections, diabetes, and so on. Okay. So Chirag sir, so you can comment on this hyperglycemia part, on this hypersensitivity part first. Have any bad experiences of any taxane hypersensitive to that matter, and how do you tackle those?
So once in a while it happens with paclitaxel particularly. It doesn't happen so frequently with docetaxel. In all these years, I had to ship my patient to ICU only a couple of times, not a very frequent occurrence. And after the interruption for maybe half an hour, 1 hour, giving extra dose of antihistamine and extra dose of steroid, most of the time I am able to restart and complete the planned infusion of both pacli as well as docetaxel. So that's my experience.
So how do you look at, sir, if conventional taxane, or for example, conventional docetaxel has got a severe hypersensitivity? So how do you look at an option? So the hypersensitivity is usually because of the tween 80 or the polysorbate that is there along with that. So how do you look at this option of not giving docetaxel and giving these alcohol-free or dosi-aqualip regimens for these situations where there is a history of docetaxel hypersensitivity?
So if the patient is having, so we don't know whether the hypersensitivity is because of docetaxel or polysorbate, but it is reported that it's because of polysorbate, not per se because of docetaxel. So if the patient had severe hypersensitivity reaction, I think in the subsequent cycle I will tend to use one of the alternative formulation.
Okay, okay. Okay, so these are other adverse events, cytopenias, and we use GCSF, and with, for example, with TPF, when we use, we use a lot of GCSF along with that. So fluid retention, and this is sort of under-recognized thing, and this happens when it is cumulative. So Dr. Kripa, so on which situations would you put a patient on prolonged docetaxel, 8 cycle, 10 cycle, 12 cycles? For example, in CRPC there is no limit. You can keep giving, and we have also seen in stomach where we give docetaxel maintenance, So all these we have used docetaxel for prolonged periods of time. So how do you see fluid retention as a challenge? Patient keeps saying pedal edema, and how difficult or how do you look at this problem?
So 80% of patients do have mild pedal edema, like that is acceptable, but most of the patients like who are really concerned is to us is a pleural effusion and all. Significant pleural effusion is a different concern, so that do happen in less than 10% of the patients, but mild pedal edema is acceptable. Sometimes if it is causing difficulty, we do add low dose diuretic for 7 days like that.
Okay, so I think then coming on to quickly to lung toxicity, docetaxel induced lung injury is really, 1 to 5%, which is not that much recognized. Bilateral interstitial lung disease, exertional dyspnea, with higher dose, higher incidence with high dose and weekly regimen, pre-existing lung disease, the higher risk. There are various types of issues, and the mortality is quite high with this lung injury. So, Alice, any comments and experiences with docetaxel lung injury? How frequently do you do imaging? How do you assess that?
Very rare. Till now, only one patient, and not rechallenged. Head and neck patient, I have not rechallenged for lung toxicity. Hypersensitivity, yes, I have rechallenged with a new molecule, but even that patient with lung toxicity, I have not used even the new molecule.
So Vijay sir, lung toxicity in docetaxel, it's sort of underreported, and we underestimate this.
We have seen this coming in crops, and a few years back, quite a few of our patients started having this ILD-like picture after docetaxel, and our pulmonologist Dr. Tandon actually diagnosed them as docetaxel induced, and we have got a bronchoscopy done, BAL, lavage, everything done, and when I say few, it was like 6-7 patients, but our use of docetaxel also was high. And that was the time we actually, I don't remember the brand which was there at that time. That time was a time we made a conscious shift to dosi-equilib. That was the way we started using dosi-equilib, because we were fearing for interstitial lung disease. And this was mainly, Dr. Joshi is not here, this was mainly seen in the prostate cancer patients. And we shifted to one for next few months we didn't have any episodes on dosi-equilib of such reactions. But slowly we again have shifted back to the conventional docetaxel, and again such a crop again has not happened. So whether there was a cause-effect relationship, whether dosi-equilib stopped it, or it was just because of one brand having batch, having some impurities, we really don't have that answer. But this is what, as a change we had done when we saw quite a few patients developing lung pneumonitis, which was alleged because of docetaxel.
Okay, so I think this already Dr. Ashish discussed all these things. So I'll just show a real-world case of, how docetaxel induced lung injury. This is a 55-year-old lady, diabetic, hypertensive, breast surgery done. So this is docetaxel induced lung injury, and then we went on to give more docetaxel and it recovered. So, I mean, I'm not saying that we have a big study saying that docetaxel will have lung injury, docetaxel doesn't have. This is some rare instances, as you also mentioned, that docetaxel is sort of lung safe. So the advantage of docetaxel over docetaxel, number one is hypersensitivity. I think we all can agree, and number two, this lung injury in some anecdotal cases. So,
Chandrakanth, I'm not sure how many, if you have a docetaxel induced lung injury, how many of us would be comfortable changing to dosi-equilib and give? Most of us would be like, once the patient comes out, we might like to change the drug. What would be your opinion?
Agreed. I mean, if I can replace docetaxel with paclitaxel, I will. Or I mean, I will not want to re-challenge with docetaxel with this type of lung injury.
So, true, sir. I mean, it's not the rule, but there are some anecdotal cases where we have changed, and probably we want to have more data before we say that this is safer than the conventional docetaxel. So this is all what data we have. We don't have that great data to support anything, but this is what in this short time we can have discussion. Okay, any
Because
more
the-
final comments and we can conclude.
The challenge with the hypersensitivity is we are not exactly sure whether it's polysorbate or docetaxel. Lung toxicity is most likely due to the molecule rather than the preservative.
So I think it's quite well established that the hypersensitivity is mainly because of the vehicle and not due to the molecule as such. So this we can take because with docetaxel, if you look into the hypersensitivity is significantly low as you look into the data. So hypersensitivity, I think there is no doubt. As far as efficacy, I mean, we don't have the great data. Toxicity again, other than hypersensitivity, the data for other side effects are not that great. So I think with this, I think we had a reasonably good panel discussion in a very short time, and I would thank all of you for your active participation. Any final comments? Otherwise, we can conclude the session. Thank you.
I think the company should do a randomized study.
Thank you.